Welcome to the Core EM video series podcast. Today, we're going to be taking an interdisciplinary look at concussion. So, in the emergency department, we see a lot of patients with brain injuries. We know how to rule out the bad stuff, the bleeds, the fractures, the contusions. But the fact is, a lot of our patients end up with concussions. So, today, we're going to do a little deep dive in what are best practices as of 2025 for concussion. So I want to know, what are the historical and physical exam findings that we need to look for to make the diagnosis of a concussion? What are the best recommended pharmacologic therapies and non-pharmacologic therapies? And what should we be advising our patients? Should they be doing brain rest? Should they return to activity? And what's the time frame that patients can expect? So to answer all these questions, we're going to speak to a neurologist. Our guest of the day is Dr. Leah Croll.
So my name is Leah Croll, and I'm a neurologist at Maimonides and an assistant professor at SUNY Downstate.
Let's say that, we're seeing a patient after a head injury. We obviously know how to rule out bleeds. We have our Canadian head CT rules. We have CT scanners. But let's say we've done that. What are some things we would just see on the history that could point us towards, yes, this is probably a concussion? And we're talking about acutely, like the injury just happened, maybe a half an hour ago, maybe 2 hours ago, maybe that day.
So the hallmark historical feature of concussion is going to be this head impact that's coupled with a neuropsychiatric disturbance. So typically that will manifest as confusion. Sometimes you can get loss of consciousness or amnesia as well. You don't have to have all of those things, but usually there will be some sort of history of a transient state of being confused, of not remembering what happened, of being unable to retain new information, and potentially of a transient loss of consciousness.
And then what about on the exam? Are there any physical exam findings that point us towards a diagnosis of concussion?
So the tricky thing here is there's no necessary exam finding that you need to have in order to diagnose a concussion, but there are some really helpful hints you can look for on your exam. So the first is going to be incoordination or imbalance, and the easiest way to look for that is to have the patient do a tandem walk. If they're stumbling when they're trying to do that, if they really can't stay upright when they're doing it, that's a sign that maybe there's a concussion there. You also want to check out their neuropsychiatric state. So often you can see people with a very vacant stare. You can see people with inattention. They can be very emotional. They can have trouble retaining new information. Checking for those sorts of things is also really important.
Awesome. All right. So let's assume that the patient does have a concussion. What recommendations should we be giving to these patients for the acute phase of the concussion? It's going to be a week or two before they see you in the clinic. So what should we be telling these patients to do, to think about, to worry about?
So on a very basic level in the movies, there's often lots of talk about don't let someone fall asleep. And hopefully most of us know in the medical world that that's not true. You certainly do want to let people sleep. You do not need to be afraid that they're going to rest. That's fine. The other sort of thing that you used to hear about a lot is sort of this idea of rest is best, or complete brain rest, which was just telling people they had to basically go home, sit in a dark room, don't stimulate their brains at all. And that's really too far in that direction as well. So
That's
now,
interesting because I feel like I still hear that. That's something that I do hear people recommending.
yeah, there is a lot of evidence now that kind of this complete brain rest can actually slow down the concussion recovery. And really, we're leaning more towards what we call a relative rest period. So the first 24 to 48 hours after the concussion, we typically tell people, don't go totally back to your normal life, but you don't have to do nothing either. You can sort of take care of yourself at home. You can cook your food. You might watch a little TV, but you just want to make sure you're not getting too much screen time, that you're not exerting yourself too much physically, and certainly that you're not exerting yourself too much cognitively. But again, that's very different than complete brain rest, where you sort of have to power yourself down.
So you're saying for the first day or two, you're saying relative brain rest. How do patients know what's enough screen time versus too much screen time?
Yeah, so this is the question that every single patient asks me when I talk about screen time with them. And I think there's really a couple of things for patients to know. Number one, the evidence, it really pertains to those first 48 hours after the head impact. That's when minimal screen time is going to give you the biggest bang for your buck. And that's particularly true for adolescents. So I'll tend to tell people, you can do a little television, but if you're starting to get a headache, if it's starting to make you feel really tired or dizzy, go ahead and turn that off. Maybe do something else, talk to your family, read a book, listen to a podcast. Certainly video games are something that I find it really exacerbates concussion symptoms for people. But it's a lot of listening to your body as a patient and really knowing, what, this is starting to feel kind of bad, so I'm going to stop it.
Okay, so listen to your body. If you develop concussive symptoms, headaches, irritability while doing something, back off from it. Okay, now take me from 48 hours to out to 2 weeks. What should they be doing?
Okay, so after that first day or two, actually, I tell people probably the most important thing that they can do is a little bit of light physical activity. That has been shown to really accelerate concussion recovery. So I want to be careful not to encourage them to go and play football, right? We don't want them to get hurt again. We certainly don't need them running a marathon right away, but something like a brisk walk is really great. In fact, that's basically what I advise people. Go for a walk, try 20 minutes. If you can do longer, great. If you can't, that's okay. And then once you've started that light physical activity, it's really up to the patient, again, to kind of gradually increase what their body is able to tolerate. Try again the next day.
That's great. So relative brain rest, not complete brain rest.
Exactly.
Any specific recommendations for pain control? Is there anything specific that works better for concussion?
So there's no specific pharmacologic therapy that has been proven to be particularly effective in concussion. Typically and most commonly, patients struggle with headaches up front. And so they should be encouraged to reach for a Tylenol or an NSAID in that acute phase. We don't want to encourage them to take Tylenol and NSAIDs around the clock or for many days in a row. We really want to limit that to just a couple of days because it can result in rebound headaches and medication overuse headache. So if patients are still getting headaches after that first few days, then they can try magnesium. So you can buy this over the counter. It can be magnesium oxide. Sometimes it has to be magnesium citrate if there's no better option. But typically 200 to 400 milligrams is worth a try to see if it's helpful for headaches.
And that's once a day?
Once a day.
You mentioned brisk walks, but are there any other non-pharmacologic therapies that improve outcomes, decrease symptoms?
Yeah, so brisk walks are probably the most evidence-based thing to do after a concussion. Certainly focusing on sleep hygiene, on good nutrition, as always with any brain condition is going to be helpful. And really it's about that sort of gradual increase of activity, both physical and cognitive, that helps.
Got it. So what sort of time frame can patients expect from the time of injury to going back to feeling like they're back to their normal selves? Like, is this a 1 week thing, a 1 month thing? What's the average?
I usually give patients 3 sort of time checkpoints. Most people will have a resumption of most of their concussion symptoms at 7 to 10 days. The vast majority will be completely okay at that 4-week mark. And by the 3-month mark, really, we should be looking at about 80 to 90% of people are completely recovered from their concussion.
Are there any therapies that you guys would do? I'm thinking I've heard vestibular rehab. I don't really know exactly what that means.
Yeah. Tons of therapies. So, for example, many people with concussion will also have neck pain, in which case they probably need physical therapy that focuses on the neck. Other people have really predominant dizziness or blurry vision, double vision, and that's somebody who's going to benefit from vestibular therapy, which is basically a physical therapist that has special training in exercises that take you through coordinating rapid eye and head movements.
All right. So, are there any innovations coming down the pike that we should know as frontline providers?
What I'm most excited about in terms of frontline innovations are the development of biomarkers that can be used in the ER or on the sideline to determine how worried you need to be about someone, who needs a CAT scan, who doesn't. And also later on in the clinic, that those biomarkers may be used for us to monitor how someone is responding to therapies and progressing as time goes on. Right now, there is one test that's been FDA approved. It's from Abbott. It's called the iStat TBI test. It measures GFAP, which is a protein that's thought to be released in the setting of traumatic brain injuries, and it's definitely promising.
So is this like a troponin, like something that should be intracellular that's leaking out into the bloodstream?
That is the basic idea, yes. And I'm hesitant to call it a troponin just because troponin is so foolproof. We know what it means when it's positive. This is so experimental for us in concussion still, and there's still so much we need to learn. So my hope is that one day it will be like a troponin. We will really sort of understand how to interpret it and how to use it, but we're not there quite yet.
Awesome. Well, thank you so much, Dr. Cole. This has been great.
Thank you. Hopefully we can do it again.
Yeah, super fun.